So he's seen us through thick and thin from the beginning, and so we're thrilled to hear from you, Biplab. I think your career is being informed by your experience in global health, right? So that's wonderful, and we're looking forward to hearing from you.
Thank you. Thank you everyone for thank you everyone for coming, and thank you CGHE for giving me this opportunity to present my work and as the title of the talk goes, perspectives from industrial engineering from an industrial engineer. The agenda for today, I'm going to talk a little bit about the drug stockout challenge. Some of you have been to some of my talks before and have some kind of background on what that is. Then I'm going to speak about the data analysis that we did for the partnership CGHE developed with Clinton Health Access Initiative. Then I will tie in how that and my work here has led me into my research in pharmaceutical supply chain equity. And from there, I would like to talk a little bit about industrial engineers in global public health. Initially, I was thinking of maybe making like a 10-minute presentation and talk for the other 40 minutes, have a discussion. But I am going to take the use of my slides throughout the presentation. I ended up with more slides than I thought I would. But this is going to be conversational. If you have any questions, please you feel free to ask. So, drug stockouts. We have, so in low resource settings, in areas where they don't have enough medicines to supply the communities that they service, there are a lot of waste of medicines because they don't get transported on time. So for example, in South Africa in 2011, 19 tons of medicines had to be destroyed because they expired sitting in the wrong places and they didn't reach the people they were supposed to reach on time. All those red dots on the map of South Africa is a location where a stockout was experienced during that time period. So while these medicines are sitting in places they should not be sitting in, you have patients who are being turned away from facilities. So in a lot of occasions, there are a lot of programs that are launched to tackle different global health challenges, but on the floor, the reality is that a lot of times due to supply chain issues, the medicines and the therapeutics are not reaching the last mile, are not reaching the end user. So what are the impacts really? So there are health consequences and other than health consequences. The health ones are like uncomplicated infections turn resistant, inappropriate drug alternatives are prescribed, the illness becomes more severe or it increases in duration, and then in the worst case there's mortality. And when it comes to the other consequences, there is a wastage of medicines, there are loss of jobs, and I speak of loss of jobs because we're talking about places where there aren't very good public transportation systems. So you are essentially walking 2 miles to get to your nearest drugstore, though you get turned away over there, you walk another 2 miles to a different drugstore, you get turned down over there, and this is a person who's a daily wage earner who does not have a job where he can take leaves, so that keeps on accruing, and then there's like loss of jobs have been one of the non-health consequences of drug stockouts. And in the end, there are a lot of people working out there in the field who want to help, and by that I mean the health workers for the community, and they feel helpless and frustrated because they are out there and they can't do anything. They're devoting their time and their energy to help people, but if they don't have the medicines, they can't do anything about it. So with that introduction of why drug stockouts, why pharmaceutical efficiency in supply chains is important, I am going to move to the partnership that we developed with Clinton Health Access Initiative. This is a conversation we were having with them, I think a year ago, and the call went, so they said, like, we have a lot of data, we don't have the bandwidth to analyze it. And we were like, okay, send us the data and we'll tell you what we can do with it. So they sent us a bunch of files. I think there were like 7 of them. We spent a lot of time going through what we could do with them. So I'm going to present one of the pieces of the work that came out of that, which is going through this data set where they went out to the drugstores. They had teams that went out to the drugstores, and then they educated the drugstores about certain diseases, and they monitored the stock counts. And I'll tell you more about that in a minute. So that took us to, so this is how we ended up in Uganda. 38 million people. Rural population is about 84%. The under 5 mortality rate was about 69%. The major contributors to under 5 mortality were diarrhea, pneumonia, and malaria. And most villages are served by private-owned drug shops and pharmacies. So they're not federally governed. Yes?
Just to give some context, what do these drug shops and pharmacies actually look like?
What do they look like? I have some pictures actually in the slides after this. So they're essentially, they can be anything ranging from a closet, and I say that because there's one of the villages that I visited, there's a door, you open that, there are shelves and a table and a stool, and that's the drug shop. To something like you have a back storage room, you have multiple shelves, like it's a big area, you have multiple counters, so that's the range really. So we don't really know, but that is the context of the situation that we're looking at. So from here, I want to give you some idea of what the data looks like. So there were 72,000 records. Each of the record had 44 attributes to it. Some of them were location or facility characteristics, then their knowledge level data, then some of the survey details, the stock counts for all the medication that they were talking about, that they were educating for, and the buying and selling prices of those medicines. And that takes us to the objective, because when we were going through this, they hadn't gone through this data themselves. It was pretty much like, look at this data, see what's in there. That was the objective. So that's how we started, and then as we passed through the data, we kind of developed more objectives along the way based on what made sense to do using that data set. So the overarching question then, yes?
So why did they collect the data?
So the data, so they had the intervention of going out and help and educating these retailers, and they collected the data as a part of the intervention to keep stock counts, to just monitor stock counts.
But it had all this other
But
data.
yes, but what ended up happening is the organization they had outsourced this to, this whole intervention to carry out the field work to. They lost contact with them after a point, so a lot of data was collected, and then in such organizations like Clinton Health Access, a lot of people like come in and leave relatively with like a high frequency. So what ended up happening is that this data set was collected, but the person in charge wasn't really there anymore. So they just had it, they didn't know what to do with it. That's how this kind of unfolded. So the overall idea first was to evaluate the impact of these educational visits. Like, did it actually change anything at all? We didn't really know how we would answer that question, but that is what they wanted to know out of this data set. But to get there, first we had to perform an exploratory analysis of the data. We had to develop the learning objectives from that analysis, from looking at the data. Then from there, once we looked at the data, we were like, all right, maybe we can learn something from an industrial engineering perspective about what is the inventory holding behavior, and what are the changes in availability for ORS and zinc within these outlets that the data was collected for. So the challenges that were identified when we were going through the data was, so in the 72,000 records, there was not one column that gave us a unique identification for an outlet. Now every outlet might have been visited multiple times, but we didn't know which outlet it was. We had names, but names would have apostrophes sometimes they wouldn't, and it's like a lot of data entry errors, so we didn't really want to rely on that. So that was a big challenge for us. Then there was a lack of supporting document because the Excel sheet was all we had. We didn't have any program of how the survey was designed, etc. So we realized that there can be a possibility of some bias in the data set. But going through with that, we figured out how to identify uniques by combining a lot of facility characteristics like district, sub-county, village, outlet name, outlet type. Like we brought them together, and we found out we assigned one key to each row, and that became an identifier for a unique outlet. And then we ended up with 21,000 uniques, 21,500 uniques among the 72,000 rows of data. Now, to give you perspective, 21,000 outlets in this case were surveyed or were visited, which is a huge number of outlets when you think about it. So we got really excited at that point, thinking, all right, this can be a huge overall study. So we started cleaning the data set. We removed incomplete surveys. We removed any duplicates that occurred with the same data on that, and then that 72,000 dropped down to 54. And then we had 54,000 observations, and the 21,000 uniques remain the same. We were still like, okay, 21,000 uniques, that sounds great. Then we started looking at, okay, we assume every outlet was visited more or less the same number of times, but that was not true either. So there were 7,800 outlets that were visited just once, so you don't really have any data on trend for them at all because you don't know what happened to them after that. And then so on, like some outlets were visited as high as 30 times. And then, so from here, we realized that the 21,000 uniques is not going to be the number that we will be working off of. We need to find out how to subset the data. So from that, we wanted to have at least 1,000 outlets in our study. So we picked up, we picked up 1,400 outlets that had 6 or more visits, so that we can look at a trend over time, over like 6 time intervals of those unique outlets. So once we had that though, we wanted to figure out, so now that we have that, now we have the subset of the data, how do we look at the trend? Like these are absolute measures. How do we kind of see if something has changed over time? So we ended up doing this rudimentary step before we got into more advanced methods of getting into a net change. Now, what is a net change? So if you have an outlet and you have 6 visits to that outlet, and these are the stock counts of say ORS for each of those visits, we calculate the net change from the previous visit to find out if overall at the end of 6 visits, did they end up with a net decrease or a net increase in how much stock they were holding. So that's the metric that we calculated to find out, so okay, of the 1,400, who showed a net increase, who showed a net decrease, etc. So yes.
Sorry, is the net change, it's a percentage?
No, that's counts.
An absolute.
Those absolute counts.
So the count for ORS refer to like one package of ORS?
Yes. So individual packets of ORS. So the most the unit that they defined as their count for ORS and zinc. That's how that was done.
Alright. So the way you calculate this is everything is like is measured against the number in the first stock.
No, in the previous one, not the first one.
So then why did the third one is minus 151, not minus 32?
So you start with 170, you go down to 52,
Okay.
that's a change of negative 118.
Right, but
From 52, you further reduce to 19. So that
shouldn't
increases.
be like minus 33 and not minus 151?
No, that's this difference. So this
Okay.
difference gets added, it compounds over here.
Oh,
Yes.
okay.
Yeah.
Thank you.
So it's always the first. So
It's always the previous one, but the difference with the previous one gets
up.
added
Yeah.
to the net change. Yes.
And just to clarify, this is all stock, not necessarily expired or any.
No, this is all stock. Yes.
Okay.
Yes.
Biplab, in effect, it's like survey 4 minus survey 1.
It's performance anyways.
So the reason this is the way we went is, I mean, there is a reason to that, and I'll come to that in the next few slides. So, and
So just a moment.
yes,
So in between these visits, did they, I mean, it looks like they actually acquired more stuff, right? So the people get more stuff.
when? Which one are you talking? Which?
Actually cannot see.
Alright. So it depends. So basically, it's what it's trying to do is you start off with one number when you went there for the first time, and then every visit you make, you want to see how they are doing in the subsequent visits compared to your benchmark that you set in the first visit. So that's how this goes. So we did this for both ORS and Zinc, and we found out that, oh, this slide isn't showing up really well here. Well, okay.
Here you go.
That's how it's supposed to look. So, for ORS, we see that 44% showed a net decrease, 46% showed a net increase. Then for Zinc, 39% showed a net decrease, and 53% showed a net increase in stock levels. But that really doesn't tell us much, does it? Like it gives us some idea of where there has been a net change, but who are these outlets that actually showed a net increase and vice versa? And that's where we go into a little more detail of a graph that is not fun to look at. But what it tells us is, what we did is, in essence, the blue line is the plot of the net change. So every outlet, so this outlet for example, so on the horizontal axis we have these individual outlets. Right here we have the first outlet that showed a net decrease in stock for Zinc of about minus 390-ish, all the way up to the last outlet that showed a net increase in stock of about 180 units. And what we thought is, what does it tell us about how much they're actually holding in terms of inventory? Like, it gives us a change, but it doesn't tell us what is the average stock that they hold. So we plot the orange bars, that is the average stock levels for Zinc for those outlets. And what we really saw here, and not to go too deep into this graph, was that the outlets that showed a very high net increase or net decrease overall had a higher average stock than the outlets that didn't really show much change. Like this line kind of, the fitted line kind of goes up on both ends where there is a huge net change. So that's what we're going to take from this and then find out. So if we're saying there's a net increase or net decrease, does that actually mean there's a trend? And the reason I say that is because, for example, if you started with 170 and you had 0 on the next visit, for some reason you didn't have any, and then you had 70, 80, 90 and 100 on the subsequent visits, according to our method, it would still classify them as a net decrease, but there's an actual increase in the trend of how much they're holding. So that is why we got the individual measures and measured it separately, because that takes us to this slide where we fit a slope to that data for each outlet, and we found out that for those who we classified as net increasing, 89% of them actually showed an increasing trend. For those who we classified as net decreasing for ORS, 76% of them actually showed a decreasing trend. So it kind of corroborates the hypothesis of the educational visit to the outlet actually working towards a net change. Yes?
Might an alternative explanation be that, you know, the shops that are going to have the higher stock count are bigger, they're serving a greater population, they have more reserves and so on, and so they can afford to have these kinds of perturbations, right? Like they're starting with an overall higher stock count, and so they can afford a bigger sort of perturbation in the numbers that they carry. Whereas a small drug shop that maybe only carries 5 sachets or 10 sachets of ORS at any one time can't really afford,
yes,
you know, a lot more than that. They don't have the room to move.
Exactly, and that is the size of the drug shop is one of the metrics that was not visible in this data set. And there's actually, for my last few slides, I forgot to mention this, there's a small light bulb at the top right corner, and there's a reason for this, because all of these analysis, the ones with the light bulb, led us to kind of think about something else in that direction, which I'll come to in my next slide. So we kind of corroborated for Chai that yes, the ones that showed the visits did actually work. The ones that were, the outlets that were visited 6 times, the overall stock counts did increase, and this was mostly because of this piece of analysis where they wanted to know the just pure availability. They said that we are not in a situation where we aren't there yet where we're looking at stock counts. We want to look at, is there zinc and ORS available, 0 or 1?
At least 1.
Yes, so like in a binary, yes. So, and this is what we saw with the data, that as the number of visits increased, the availability for ORS and zinc did increase over time. And that takes us to the conclusions for this work, which was the drug outlets that were surveyed showed, they showed a rational behavior in drug stocking, because in another piece of analysis we found out that those who were carrying a very high stock level in the beginning, irrespective of number of visits, reduced their levels, and those who had a very low stock level increased their levels, and it showed that they all came around to this median, which seemed like, you know, reaction to market forces and not reaction to the visits. Then, given lower initial stock levels, the educational visits showed an increase in stocking for both ORS and zinc. So the intervention worked, but the light bulb moment for us was we don't know anything about the places that these drug shops serve. We don't know the demand. We know one side of the picture. We know what exists. We don't know how much is needed. And that's the data gap that kind of then motivates my work to find out where is this demand data, which is one, and the second is where is there an equity measurement that kind of that superimposes the supply that exists over the demand that we don't know. So, and I use the word equity because every region has its own need, and the best way to understand that is equality is not always equity, because depending on what's available, depending on the facilities that are available in a village, depending on a lot of other demographic conditions, the need is going to change. So how do we really find out what the need is? And this is what drove us to work on this piece called the Stockout Severity Index. Yes?
So, for most of that, maybe you want to shed some light on the nature of the intervention. How do we know the intervention worked?
Because the nature of the intervention was to go to the drug shop and educate them and record the stock count of that medication that they were giving education for. And then over time, we saw that with the visits, the availability overall increased of the medicines.
And the metrics of availability here is whether you have a new person stock or you have a new person.
No, the metric of availability there was binary, just do you have it or do you not have it? So do you have ORS and zinc or do you not have ORS and
So
zinc?
the number of times you just didn't have it at all, right?
Yes, so the number of times that they didn't have it reduced over time.
It's just that availability is just the proportion of facilities that had at least one zinc packet or one ORS sachet
Yes.
available.
Yes.
The one caveat about the intervention worked is that this is in the absence of a counterfactual, meaning it's in the absence of a comparison group, right, that didn't get the intervention.
Mm-hmm.
And so you don't know in general over time in Uganda over these couple of years that all shops, irrespective of whether or not they got the intervention, just generally have
Yes.
cases or not. So just to be careful about language, I think is important.
Yeah, absolutely.
So
Yes.
in the absence of that comparison group,
In
it appears that.
yes, yes, that is correct. Yes.
On that note, do we know if there were simultaneous government interventions to talk about this problem that weren't individual visits but might have been more public information?
We don't know that. So that's like one of the challenges that I identified earlier, is that we have no other information of what happened at that time, what the methodology was. We didn't know.
But CHI partners with the government, right? They partner
Yes,
with the
CHI
Ministry of
does
Health,
partner
and
with
they're
yes.
very clear on like what CHI is doing.
Yes, that is true. Yes, so the government knows what CHI is doing.
Did you see a difference between the drug shops that were visited 6 times compared to like when they said 30 times? Because I would assume
There
the
were.
more you went in,
Mhm.
the more your stock potentially would be a little bit more. Did you look at like stability, or was there no difference?
Actually, this is still work in progress, where we're looking at now how the number of visits affects the availability. So that we're still working on actually. Yes.
Just tangent to Elizabeth's question.
Mm-hmm.
So I'm just wondering if like the area where you conduct the study had lots of like international NGOs involvement that can potentially introduce some interventions and mix with whatever the content initiative is doing.
No, and that is a good question, but again, like with the same challenge that we faced was we did not know how this was conducted and what was actually going on. We didn't know how the outlets were selected, why some outlets had as high as 30 visits while others had just 1 visit. We really don't have that information. So for us, in that partnership with CHI was to let them know if there was a change in availability over time, over their visits. So that was the objective. So yes, coming back to the stockout severity index, which came up as a thought of not knowing what the demand is like. So we want to bring together databases that have supply data, demand data, the location data, and kind of combine them to look at a set of villages. So if you're looking at a district, so you look at all the villages in the district, and then you put in all of these parameters of what the location or demographic information, we put in like what the kind of population is, what the prevalence rates are, etc., and then get a relative ranking of where one village stands with the other in terms of how severely they are impacted by stockouts. So stockout distributions exist, but they are not the same overall. Some place, for example, malaria, like if you have 2 identical villages with the same number of children under 5, but one village is near rice paddies versus the other village which is relatively dry, the first village is likely to need more malaria medications because rice fields will attract more mosquitoes. And so to kind of bring together those pieces of information to actually capture what the needs will be, within a geographic boundary, like for example a district or a county, etc., among the villages that reside there. And that's the idea behind the Stockout Severity Index. And using this index is how we want to prioritize who to service first. And one of the ideas was to develop mobile pharmacies, which was essentially you have a bunch of nodes which are villages, and you have different demands for each village, and you want to set up a route for how do you want to serve these villages in what priority. So usually this is used in industrial engineering, in operations research, management sciences, to reduce cost or to reduce travel time. We want to use this coupled with the Stockout Severity Index to reduce the inequity in the system that it serves. So before we get into that, I'm going to try this little experiment here. I believe everyone has a phone. Can you please go to your phone, open the browser, and put in this link right here? You don't even need the HTTPS actually, you can just put in edc.ch.
Are you telling us the vote?
Yeah, yes, please do. So there'll be a question that pops up, it's multiple choice.
But it's not the same question.
Can you pick more than one?
Yes, you can pick more than one. So is the question, does it say where could an industrial engineer work?
Yes.
Good. We're all on the same page. Excellent.
Did you start your talk with a definition of an industrial engineer?
No, not at all. I want to know what you think.
We're testing previously held knowledge.
Did you make this?
Or assumptions.
I did.
How many questions are there?
There are a few. Alright. Okay. So this is what you guys think.
Wait, okay.
Right.
It's real time? Is it real time?
Yeah, it's real time, so don't change anything. Yeah. Okay, so most of you think like we work in Amazon, FedEx, UPS, that kind of situation, and then I'm surprised a lot of you say kitchen of a large restaurant, because that is also true. In fact, all of these options are correct. That is how versatile industrial engineers are. We kind of work in all kinds of situations. And with that, I will move. And the reason I wanted to show this is because if I thought the group was of the idea that there are some areas that we don't work on, I would say that no, that's not true.
You stole your phone.
Yeah, no, it's fine. This is what I was expecting. This is great, actually. And now we're on question 2. So,
should I be a grocery stocker? That's what I should consider. You're asking what I consider.
what would you? Yeah, in your regular day, what would you consider while restocking on groceries? And this is not a test. This is just to put the idea in your head that there are these factors that people think about when you're restocking groceries. And similarly, when you're restocking medicines, there are some very similar factors that one thinks about. And moving to which takes me to my last question, that if you were in charge of developing a medicine delivery truck route, what are the factors that you would think of, or how would you rate these factors? Like, pick the 2 most important to you.
Pick one. Yeah, we can only pick one.
Oh, you can only pick one? Oh, well, then pick the one most important to you. Oh, nobody thinks capacity of the truck is important? Anyways.
If you don't have any one of these, you're gonna have a
If you have no demand, you need a truck.
Yeah.
How many tons of medicine are we moving into?
Yeah, it's just a motorcycle.
Okay, so the idea was to get you to think about what are the different things that you think of when you're either restocking something or when you're trying to decide a route for a truck. And what I'm trying to say is, if we all know this as people who are not industrial engineers, as most of you are, why are we important? Like, what makes us the people who can do this kind of work? And that takes me back to my slide, which goes, alright, so I keep saying that we want to abstract the reality into math, and then that's how we work. Like industrial engineers, what we do is we take what's happening in a given situation, we make a math model, whatever that means, and then we improve the situation, or we create certain solutions. Now, how does that really work? Everyone can think of the factors that are important, but why is this field important? It is because I am looking at, in my solution, I'm looking at a village, looking at 20 villages with 30 days, and I have one truck. I want to figure out where I should send that truck for the 30 days, like what the routes should be. The complexity of any problem goes by 2 to the power n being the number of variables. Now, what is a variable? A variable is whether is my truck in village A on day 1, yes or no. If it is, it's 1. If the truck isn't there, the variable is set to 0. That's all that it means. Now, if you have 2 villages and 2 days to plan for, you have 4 of those variables that you need, those choices that you need to make. If you have 3 villages in 3 days, you have 9 variables. Now what happens is each variable is 2 choices, and that's how the complexity ties in. So basically, if you have 2 villages in 2 days to plan for, you have 16 choices to make. If you have 3 villages in 3 days to plan for, you have 512 choices to make. I have 20 villages in 30 days in my problem. That gives me 600 variables. That gives me 4.14 into 10 to the power 180 choices to make. Today's parallel processing computer makes about 16,000 choices per second on a good day. So the time to solve this problem is going to be 7 into 10 raised to the power 175 seconds. How much is that really? This is the sun, and the sun is expected to cool down in about 10 raised to 17 seconds. So that's about 500. That's about 5 billion years. So if I want to run my problem in the traditional sense, that's never going to solve. And that is why developing algorithms and developing heuristics to come up with not the optimal solutions but good solutions is important. That's where my work comes in. So, and that brings me to this wonderful graph that you've seen before, the Gini coefficient. So we figured out that we need to send, okay. So we figured out that we need to send a truck among 20 villages, and we want to figure out how the income, we want to see how it's impacted the system. So the Gini coefficient was used in economics, where you have 100% of income is distributed among the 100% of the existing population. If it was a perfect system, it would be that everyone got the same share of the pie, so it would be a straight line. So we developed our routes and we implemented it, and it turned out, so this is the perfect system line, the gray one. The blue one is the current system. The orange one is with using the trucks to go around for 30 days and see how the impact is if we supply drugs for 1 day, and then if we supply drugs for 2 days, you see the change in the yellow. it's not a perfect, like the curve is not perfect simply because this is a heuristic, this is not a pure expansion. So it localizes in certain areas, and we're working to improve that. So that's kind of the work that I have been doing and the results for that so far. And that brings me to, what did I do when I was in Uganda? What did I learn?
Can we go back?
Oh yeah, absolutely. Okay.
So, modeling is often built on some data that then gets sort of extrapolated and expanded, right? So how did you construct this? What information did you use to actually generate these curves?
I got my data from, my location data from a Stanford database. I got my stockout data from the CHI data. I got my demand data, prevalence data from DHS and WHO, and I kind of tied them together to then work on, to create my data set that I would run the trials on. So.
And one other thing to keep in mind, of course, is that a child who's acutely ill with pneumonia or diarrhea needs the meds that day at that, as soon as humanly possible, not 10 days later. And so that is going to affect the model. So is it really a mobile pharmacy or is it a mobile resupply that's taking the meds and ensuring stock availability at all times, but that actually there's a local depot that holds the stocks at all times?
So the idea here was if we didn't have any collaboration with the local pharmacies, how would we do it? You go have a regular schedule of when to set up shop at every village and kind of run that through. And I understand that there might be cases where someone might really need it and the truck is not going to show up for 3 days. But that is one of the limitations of this work. This is more to say that there are places that are so bad that they don't have anything at all. So how do we kind of re-up that? And there are other forecasting methods that we could use to forecast which villages will see a stockout and then try to go there first. So yeah.
I think that we should talk about this because I think this idea of like a roving supply method is a really reasonable one. It's just that if you want it to be realistic for the public health need on the ground level, then it should meet that. And of course, this works for chronic disease medication, right? Where somebody they get their meds for a month, and that's fine for them.
Yeah.
But the acute infections that are the leading causes of child mortality, this is less of an immediate solution for. But there's certainly a lot more discussion to be had. I just wanted to raise that as a.
Would you think
there are community health workers
in
many, many low-income countries. So Ethiopia now, for example, national scale of the community health extension workers are everywhere. There are paid cadre of workers, and they are selected from local communities. They're relatively, they're locally placed, right? So that's a group that would receive at least the meds that are relevant for high burden child mortality.
Right. That, this is something that I had thought of when I was working on this and the initial idea, and that became a separate idea because that was more of a resupply system, not a show up one day with your meds and leave. So that is also something that is on our radar, but a lot of the characteristics change of the problem then. So we are thinking about that and ways to kind of like build the bridge between what we are doing here to kind of to go there. So this is definitely work in progress. Like by no way this is complete, but yes. Any other questions? All right. So takes me to my trip to Uganda, which pretty much was doing what an industrial engineer does when he's put into a new system, which is go understand the people, understand the system that you're working in, explain what industrial engineering really is, what we do, because it's not very intuitive. People think we work in manufacturing, and that's just not true. I mean, it's partially true. And then about how can an industrial engineer help. So I'm sitting in a room with people who are working with pharmaceutical supply and distribution systems, routing problems, and inventory handling systems. How many of you think now that this is an industrial engineering / management sciences / supply chain logistics engineering problem? Raise a show of hands. Perfect. There were 20 people I was talking to in that room. Everyone was an MPH. There was not one supply chain engineer who was working on this. Like, none at all. So that is kind of what I came back with, is that sense of the need. The need, to design more efficient supply chain systems. The need to work across disciplines to really understand the problems of global public health. The need to measure equity from looking at the kind of work that is currently being done in other areas. The lack of awareness of industrial engineering work and how we can help in these systems, and how we, and our responsibility really as industrial engineers to be a part of a bigger system and to help that machine run more smoother. And I know that we don't have time for this right now, but I did have a couple of questions for the group saying, can you think of, so I spoke about the severity index, the Stockholm severity index. If you can think of any data sources that you can add or that you know of that I can use in that equity measure, please let me know. And I wanted you to, now that you know about what we do, I want you to think a little more about how an industrial engineer could work in your field and in your field of work from your discipline. So, do we have time for that? I mean, if you have thoughts, we don't have to get it on paper right now, but yeah. Oh, we have 5 minutes, sorry. So, I want you to take a minute or take 30 seconds to think and give me what your ideas are on these two questions. Yes?
Does the Ugandan government have surveillance data available on the area, for example?
They might have. Ugandan government won't have it, but there might be other organizations that might have collected it.
National?
Yeah, national area survey used for the area.
Demographic and health survey data would have 2-week prevalence.
Yeah.
It's going to be relatively small sample. I don't know when their most recent, these are these nationally representative surveys that are done in many loan and
the 2015.
It's about every 3 to 5 years. So we don't know when their last,
2015 was
2015, yeah. And it's probably on the order of 3,000 to 5,000 households per country.
Yeah.
So it's a nationally representative sample. You're not going to get a lot of granularity about individual regions.
Yeah.
But that's.
Yes.
What data sources are you using now?
Right now, I'm using the data we have from Clinton Health Access. I'm using the DHS, the Demographic and Health Services data. I'm using, there are some data sources available with some NGOs that I bump into that I consider, but then WHO has summary level data that sometimes I need, so that's pretty much what I'm using right now.
Well, so how directed and small does it need to be able to be useful to you? So obviously nationwide level data, it seems like it's not very useful worldwide.
No, but that's where data synthesis comes into picture with trying to figuring out how we can use those numbers and somehow calibrate it with a certain confidence interval to suit a smaller sub-region, so making some assumptions there. So I've worked with much bigger numbers, on a nationwide number, and brought it down to a district level to kind of be representative in some way, but with the information that yes, this is an assumption, and clearly stating some assumptions there. So the best scenario for me will be to have village level data for the village, for a small set of villages, even if it's 30, 40 villages. I would like to know what prevalence rates are, what the stock levels are, what the demographic information is for those villages, but that's fine. Yes.
What do you know about healthcare records within the country?
What kind of healthcare records?
So I was in West Africa for a while, and the local health centers would keep, like in a musty old 3-ring binder,
Yes.
they would keep records of all the people who had come in, and they would total them up at the end of the year, and you could get, a slightly flawed, but it's still there. It's a number, approximation of how many malaria cases there were, how many diarrhea cases there were.
Where can I find this?
specific
Like,
village.
is there a digital, like, is this then translated anywhere?
Nope.
Okay, so this is that,
It's in a binder.
yeah, I mean, I've seen it. When I was there, I was going through when I was meeting with the drug shops and pharmacy reps, they were actually surprisingly very good about keeping records about what they sell. The problem is all of those are really old notebooks that are hard to translate on a larger scale, and they have their own system of managing it. So it exists. I've seen them. It's just to think of translating all of them electronically is I don't know how I would do that. That's the issue. You had a question? Okay.
Oh, I did actually.
Yeah, that's what I thought.
But I think that was an answer to my question. I was
Okay.
wanting you to go back to what data sources you do have so that we have an idea of what that
Mhm.
is.
Okay.
DHS, of course, so there are the household surveys, there's also the service provision assessments, which are the
Yes.
health facilities
You got it?
surveys.
Mhm.
But that's not drug shops at a local level, it's really higher level health
Yeah.
facilities. There are a number of sites across Africa and Asia where there are demographic and health systems. So like these places where they do bi-weekly visits to the home to do syndromic surveillance for a major cause of child mortality, diarrhea, pneumonia, and fever surveillance for malaria.
Right.
So I'm thinking about one in Western Kenya or in Kibera, which is in Nairobi, and might be able to find some stock level information.
Yeah, I mean, I'm
So
realizing.
that might be a way to compare, and you need relationships with people who run the DHS, those demographic and health survey systems, demographic, right?
Yeah.
Along with the service level.
What about any relationships with Makerere University in Uganda and research that's
Just
being done?
depends on whether those, there are those communities where they're doing the periodic, where they're doing the surveillance. So, like, I know in Kenya they do, in the Gambia, in Mozambique, like, there are a number of sites around the world where those kinds of systems have been around for many years, and they're kind of well recognized. So actually, if you look at the GEMS, there's a data source that London can tell you about it. 7 sites in Asia and Africa where they have ongoing syndromic surveillance.
Okay.
So maybe there's one of those might make sense.
Yeah, definitely I'll take a look at that, for sure. So I guess that brings me to saying thank you. It was not all work while I was there. I'm the guy in the red helmet on the left. Very scared. This is the first of the 9 rapids, all grade 5.
That's
A
cute.
lot of fun. Like 2 seconds after this shot was taken, we were all underwater and the raft tipped over.
I'm so glad.
It was so much fun.
Biplab, I love the difference between your expression and the guide's expression.
I was like, no. Yeah. It's definitely a lot of fun. So, yes. Well, with that, thank you so much for being here.